Likewise, huge thanks for having me here. And just to clarify, I work in a charity which is a think tank, not dissimilar to OECD, much smaller, and scope and scale as well. So we cover the whole of England. And my job, not dissimilar again, is policy analysis, research, and really trying to track what's happening and influence the direction of travel. And when I was asked to speak at this, I kind of looked at the areas that DeStress had focused on, and the first thing that sort of came to mind is, where do I think policy has an impact? Where can policy change things? And it also then led me on to think of, well, where are some of the negative impacts of policy? And then finally, where some of the opportunities exist. And I guess when I think about this, my job is really about understanding complexity, and it's really come out in some of the narratives I've heard this morning. And also a core part of my job is realism. What is going to change the lives of people and the lives of people experiencing mental health problems, but also people in our communities. And I guess a final component of that, and which I'm increasingly sensitised to, is how effective is that policy and the impact of policy on those with the greatest inequalities, so taking that lens, both population and inequality. So I'm going to give you a few tasters of our thinking in these areas. And the slides are as much as having a picture behind me more than anything else. And I guess when I sort of picked up on the moralistic narratives, the first thing that really came to mind was time to change. And I've been around the mental health world for a long time, and my sort of journey through this has also been through experiencing mental health problems myself during my teenage years and onwards. And the sort of time to change and the movement that's happened as a result of that, honestly has changed the way that we talk about mental health in this country. And I would probably argue it's socialisation of mental health and mental illness to some extent. That these are things that we talk about with our friends, they are things we see on the television, and there are things that people in power talk about now. At the same time, this movement and the support for this within policy hasn't been ubiquitously positive. And at the same time, people with mental illness and particular types of mental illness remained marginalised as part of this narrative. And a part of that is also the complexities of mental illness. And that kind of brought me on to thinking about the unintended consequences of policies. And I'm just going to touch on this because I know we've covered some of this in some of the previous presentations. And again, the first thing that came to mind is around benefits and personal independence payments. And for all the policy and its agenda, underlying agenda, actually one of the key components of that is that the measures that we use to look at disability in this country are weighted towards physical disability, and we've not really thought through that far enough about how this impacts across different communities and different groups of people. And that's meant that people with mental health problems have been disproportionately affected. And the final part of this is really thinking about policy within a context. And it's there's a juxtaposition here, and we also heard it from the research earlier, that what we know is most people with mental health problems want to work, and employment is a really great way out of poverty. At the same time, we also know that when people are in good quality work, it can greatly support mental well-being and also support mental health for people with mental illness over a long period of time. However, we've had recent policy to try and provide those opportunities to support people into meaningful employment and work, but they've come at the same time as we've been going through austerity and changes to the benefit system. And together, these have been experienced by people with mental health problems as a moralistic judgment on fitness to work and the legitimacy of their mental health in the first place. So I'm going to just pick up on the rise of talking therapies. And I guess the first thing to say is IACT is a programme that has had huge success. It's probably one of the most successful mental health policies in the last decade. We now have expanded access for people across the population, and other countries across the EU and more widely look to us in terms of how you can provide some intervention at a low level at a population scale. Given that IACT is a very particular model, and it is aimed at a particular group of people and delivering a specific intervention. What it was never really set up to do was to address the more complex issues people experience and to go beyond that CBT intervention. And at the same time, probably the scale of need wasn't predicted and the complexity, and subsequent policy to this has been slow to respond. I think this is a sad and sort of a bit of a, a bit of a challenge to policymakers, because in some ways, the lack of progress in terms of recognising the complexity and responding to that has in some ways undermined the actual value of IAPT and CBT, because many people really benefit from these interventions. But when it's the only option and there's little else to deal with the wider issues, it can then seem to negate those issues and medicalisation of social problems, and in some ways serving a malign purpose. I want to pick up on the challenging facing GPs, because I think this is a really interesting area, and I think it's an area that we have evolving policy at the moment. And I guess the first thing that came to mind is this is an age-old problem. In the 1980s, we embedded mental health nurses in primary care. It didn't kind of work out, and now we have a new plan to embed nurses in primary mental health care. And I guess there's a challenge about what the solution is. At the same time, the nature of primary care has changed, and I think this is an interesting thing, because actually a lot of the policy in secondary mental health services, so our specialist services, means that we've discharged and moved a lot of people back into the community who now live with their own mental health issues and the complexity that brings, but are expected to be supported in general practice. At the same time, we have almost record demand in general practice and real problems in terms of capacity and the number of staff we had. But this is leading to some quite interesting developments, and I guess some reflective practice as well. It's leading to practices to reach out and create links with their communities and recognising what the limitations of medicine. So, for instance, we've seen a growth in social prescribing, and the new NHS long-term plan aims to enable that. Our own work has highlighted the role of citizens' advice bureaus in primary care. And increasingly, there are a number of practices which are trying to develop their own role as community-centred practices as really a hub or an anchor within a wider community. And I think this is a movement towards recognising the complexities of health, some of the limitations, but also the strengths of medicine, and developing a much more holistic approach. I've noticed that we haven't really talked about children and young people, and I just want to take a moment to say something about this. It's easy when we get caught up in talking about mental health and communities to sort of underplay the role of children and young people. And more than half of mental health conditions in adulthood are established before the age of 14. So these are really formative years. And not only is this influenced by your individual things that you experience, but it's as much into the social and environments in which people are exposed to. And policy direction in this area has been completely lacking. Previous policies we've had have tended to be theoretical and visionary, but less practical and without ownership. And as a result, we're in a bit of a crisis in terms of the support that's available. I think this is an area that represents a real policy challenge and a real interesting area of starting. The starting point is low, and that means that we've got to think about how we use what we've got and where we're going to make the most impact. There are three kind of starting points, I think, that are interesting. The first is recognition of the value of mental well-being and the intervention at a population level. The challenge to that is it's not always clear what works, and sometimes the narrative's a bit optimistic and unrealistic. The second is access to support services, and like Birmingham have done some really interesting work there to highlight that even if we scaled up that access to reach 100% of the population, it doesn't tackle the issues of demand. So there's some questions about how far we do go with that, and also how far we need to invest upstream. And the final component is around tackling adverse and childhood experiences. This is probably the area where we know has the most evidence in terms of what actually impacts on young people and goes on to then develop develop mental illness. So we know that the more adverse childhood experiences that young people are exposed to, the higher likelihood that they are to develop mental illness, and that work was done really nicely by Public Health Wales. And we also know that disadvantaged and vulnerable children are at greatest risk. One of the real policy challenges, I think, in addressing children and young people is not only the low starting point and where to start, but this requires action across government departments. And as others, and Gregor, okay, I'll be 2 minutes, have highlighted, the huge disparity of investment privileges increasingly health-related approaches to this and less addressing the social issues. I'll finish on really our broader values on policy and inequalities, and I just want to draw attention to 2 pieces of work here. The first is analysis by a colleague of the last cross-government inequalities strategy, which ended in 2000, ended, I think it's 2000, from 1990s till 2010. And analysis of the work that went on during this time, the interventions and those areas which were broadly defined as deprived saw a narrowing in life expectancy gap and health inequalities with the rest of England. So we can do this through cross-government focus and for a focus on inequalities. And we think this population level approach is really important. Earlier on, last year, we developed a vision for population health, and it highlights 4 particular components, including the role of the health system, but also these wider determinants. As an organisation, the King's Fund recognises that the sweet spot for policy is the areas where there is clear overlap, and this will be a focus for our work going forward and our interactions and influence with government.